And after listening to an excellent lecture on how to gain longitudinal proportions, we move on to a panel discussion on how to stop growing horizontally. We are going to talk about obesity, the pandemic, which has been worrisome to us pediatricians. Now I invite the faculty, Dr. Soundaram Madam, pediatric endocrinologist, and the panelists, Dr. Venkateswari Ramesh, Dr. Papiya Khawash, and Dr.Ganavi Ramagopal, to take the dais, please.
So a very good morning to one and all. So today we are going to discuss about childhood obesity. So since the COVID pandemic, there is another silent pandemic which is going on, which all of you are aware about. So that is the obesity pandemic, and we are seeing the effects of the obesity pandemic now. In the last 1 week, I've seen 2 children with type 2 diabetes. One was a 10-year-old who on screening for obesity was found to have type 2 diabetes, and the other came with moderate DKA. So the pandemic has reached such proportions that we all should be aware of obesity and its comorbidities, so that we can effectively prevent it, and if the comorbidities appear, we should know how to treat it. So this would be a very practical one. So it will be a very good update for all of you. So we will go ahead without wasting much time. So Dr. Ganavi, please can you tell me the definition of obesity?
Happy morning, one and all. At the outset, I want to thank the organizer for this wonderful opportunity they have given to me. So let us start the session. My first question is on definition of obesity and what are the Indian cutoffs for defining obesity. So we know obesity means fat, right? It comes from the Latin word, it means fat. By definition, anything abnormal accumulation of fat which impairs health. That is a universal WHO definition which has been given for obesity. Yeah, that's defined as abnormal excessive fat. This is a problem of plenty. We know India still we are struggling with infectious disease, undernutrition on one side, but the other side of the spectrum, even the obesity has been a very serious problem, and that too post-COVID. And India again ranks second in the obesity spectrum, and by 2025 it has been predicted around 17 million obese children will be there if the scenario continues as it is on this day.
Okay, so can you tell me how to pick up a child who is obese?
So we know BMI is our only mantra we have, where it is a screening tool where we use for obesity. The BMI is calculated both in the adult as well as children the same way, but we interpret in a different way. In children, again, are growth charts, beautiful IAP charts which have been given for boys and girls aged from 5 to 18 years. We have to calculate measure the weight and height, then calculate with the formula weight in kg by height in meter square, and then you plot across the chart there where age is the x-axis and y is the BMI, and we can see that anything above the orange line is overweight and above the red line will indicate the child is obese.
Yeah, for the 0 to 5 years, can you just tell?
0 to 5 years we have to use WHO charts.
So the weight for length charts we have to use in 0 to 5 years. So we don't calculate the BMI for 0 to 5 years. So we use the weight for length charts, and when we plot it, so if it is above the 99th centile, it means the child is obese. Okay. So can you tell me why are the Indian cutoffs for BMI lesser than the Western population?
Yeah, since yesterday we have been seeing Kadilkar sir was specific for Indian data, because Indians when compared to the whites, it has been found that at lower BMI, the cardiometabolic complications, that is what we are worried about. Otherwise, we won't be talking on obesity today, because more and more diabetic, more and more coronary artery disease in a younger age. So that's why the cutoff, we have seen that in Indian population, if you see the universal definition and Indian definition, the BMI cutoffs are lesser for the Indian, means BMI at a lesser BMI, we have to diagnose as obesity. In universal, we can see more than 25 kg per meter square if we diagnose. In Indian, it is more than 23 kg, the cutoff. Same way for obesity, it is more than 30 in universal and more than 27 for Indian.
Yeah, and
other differences because of ethnic variation and comorbid disease, as I told, at lower BMI levels in Asian Indians and other Asian population when compared to white. And the visceral, yeah, whenever the cardiometabolic problem, it's always correlated with the abdominal obesity, and it is more common in Asians as compared to whites.
Is there any other tool to pick up obesity? Are you aware of?
Yeah, this whatever growth charts what we saw, and yesterday I think we would have seen all these also. These are the quick tools where the BMI quick tool, it's already the BMI is measured for you. You have to just plot on the chart and see whether the child falls into obese, overweight or underweight. And these are the charts which we use using only the waist circumference. So waist circumference, anything more than 70th centile indicates a metabolic complication.
So actually the BMI quick tool, this is there as an inset in our pediatrician friendly IAP growth charts. So in the top left corner you would see the small inset. Here on the x-axis we have the height and on the y-axis we have the weight. So you need not calculate the BMI using the calculator at all. So in a busy OP practice you can just you can just extend perpendiculars from the y-axis height and x-axis weight. Wherever it intersects you have to keep a dot. So suppose the dot you plot is above the orange line, that is between the orange and the red line, it means a child is overweight. And if the dot is above the red line, it means a child is obese. So in a busy practice where you're not able to Google and put the BMI calculator or you're not able to calculate, this way you can easily find out whether the child is overweight or obese. So these are basically for pediatricians during OP practice. So I request all of you to use it so that we can pick up early and intervene early. And the waist circumference charts, this is just for knowledge. These are available, these are also put forward by Dr. Vaman Kadilkar sir. So these are to know the metabolic syndrome risk. So they say above the 70th centile itself. Usually we have cutoff of 97th centile only in all the growth charts, which is abnormal. But here the 70th centile itself is abnormal. So they say hypertriglyceridemia and insulin resistance start to appear when the waist circumference is above the 70th centile. This is basically because Indians are thin, fat Indians, we say. Though they look thin, the abdominal obesity is more, so the insulin resistance is more at a lesser weight. Okay. Okay, question 2. Dr. Venkateswari, so we'll go ahead with the case scenario. 2-year, 4-month-old child was brought for complaints of rapid weight gain in the last 6 months despite normal food intake, and the birth weight was 2.2 kg with failure to thrive in the first year, and there was also poor suck history. Okay, during infancy, and developmental delay was there, and the developmental delay was more towards gross motor delay. Though there was a global developmental delay, you have to concentrate that there is more gross motor delay compared to the other domains. And the child on examination was hypotonic, so you can see that the child's head is lagging here. There is truncal hypotonia as well as the neck lag also you can make out in the picture below. And on examination of the external genitalia, you can see infantile genitalia with cryptorchidism and micropenis. So what is the most likely diagnosis? So before Dr. Venkateswari says the answer, does anybody want to try this? It could be, but we were thinking of Prader-Willi syndrome. Okay. So in Lawrence Moon beetle, you will have polydactyly as well. This child did not have polydactyly. So basically hypotonia with early onset obesity. Okay, so madam, you can go ahead with
so for a general pediatrician, when such an obese child comes to our OPD, we should not miss out on a syndromic child. So there are some striking features in this child. The child obviously looks a little dysmorphic, syndromic. Then there is one very important clue. This child was born with a low birth weight. But then here is a mother who's come and saying that this child is gaining weight very rapidly. This is a very striking feature of Prader-Willi syndrome. So I think this is a straightforward diagnosis of Prader-Willi syndrome. Prader-Willi syndrome is one common syndrome which we might see as general pediatricians in our OPD. So all of us should be aware of this particular condition. Though we all know that under 5 obesity is most likely to be syndromic or due to any underlying genetic mutation. Of late, in any general pediatrician will vouch for, we find lots of exogenous obesity among under 5 children. We see children who are in pre-KG and LKG who are coming with a weight of 25 kgs and 30 kgs. That's become quite common now. But as pediatricians, we all should specifically look for syndromic features when you have a child who comes with under 5 obesity. So the top 2 syndromes are the ones which we might commonly see. Prader-Willi syndrome and Bardet-Biedl syndrome. Fragile X is something which we all should always remember. Any child with autistic features who's a little obese, and it's a male child, we should think of Fragile X syndrome. There are quite a few, now that we have genetics everywhere, a patient walks into your OPD with only genetic reports. So we all should be aware of some monogenic causes of obesity where there are quite a few proven genetic mutations which can result in under 5 obesity. So this is a child with Prader-Willi syndrome. The clinical clue mainly will be they are born with a low birth weight, but then they gain weight very rapidly. They have developmental delay, predominant motor delay, hypotonia. They eat a lot, and then the main problem which they all face later is going to be an obstructive sleep apnea, which we all of us will have to manage as a general pediatrician.
Yeah. So under 5 obesity, always rule out pathological causes which are monogenic and syndromic, and only after excluding should you think of exogenous obesity in under 5. That's the point we want to reinforce here. Okay. So going to the, can you just tell a word about obesity rebound?
All of us, during the first year of life, the children have a rapid increase in their BMI. Then after the first year of age, the BMI starts coming down and they reach a nadir at around 5 to 7 years of age. That's the time when their BMI is at the lowest, when their body fat is at the lowest. You call that particular nadir as adiposity rebound. Then after 5 to 7 years of age, for all of us, we have a gradual increase in the BMI. Of late, lots of studies have shown that this particular nadir, which happens in between 5 to 7 years of age, happens a little early. Children start reaching this adiposity rebound age at around 3 years of age, at around 4 years of age. And universally, in the last 15 years, there are plenty of studies. If you Google it, you find that throughout in all possible populations, they have found that this adiposity rebound has got preponed. And they have clearly demonstrated that children who have an early adiposity rebound, it is linked to a later onset, very early obesity in adults. So we all of us have to be aware of this particular condition, and so it's as a general pediatrician, when a child comes for the well baby visit, we have to tell the parents about the importance of not overfeeding so that their adiposity rebound doesn't get preponed because they're at risk for an increased obesity at a later date. So it's very important that we are all aware of this particular entity.
So actually, like all parents say, இப்ப சாப்பிடலனா எப்பதான் சாப்பிடுவாங்க குழந்தைங்க, so they give all they give sweets which are added with lots of ghee, they give lots of chocolate. So we have to tell that chubby child is not a healthy child. So from the very beginning, we have to ensure that the child is normal weight. So never in their lifespan should they be obese, not even in early childhood. That's what we have to make sure. Like Venkateswari ma'am told, right from the well baby visits, you have to make sure that all the children are normal weight right from the beginning. Just like tracking of BP centiles, so they have seen from studies of weight that whoever is obese early on, they will continue to have adult obesity and the comorbidities related to that. So always ensure all your patients are normal weight. So Dr. Papiya, shall we go ahead with the question 3 case scenario? So this is a 15-year-old who has rapid weight gain last 3 years with no increase in height, not attained menarche, and has difficulty in climbing stairs, has mood swings, stretch marks on the abdomen, thighs, arms and breasts. On examination, the weight is 90 kg, height is 145 centimeter. So if you see the growth chart, the weight is coming above the 97th centile and the height is between the 3rd to 10th centile. So I'm telling you the last recording here. So the height is between the 3rd to 10th and the weight is above the 97th centile. And the BMI is clearly obese, 42.81. There was no goiter and the SMR staging was A3, P4, B4 and M0. There was no galactoria and there is violaceous purple striae present more than 1 centimeter width. We took the previous records and got the height and weight, and you can see that there is a clear growth faltering here. So child has absolutely not grown for the last couple of years and the weight has rapidly increased for the last couple of years. So before Dr. Papiya tells us about the diagnosis, does anybody want to guess it? Yeah, that's right. So Dr. Papiya, can we discuss about this case? Do you think, is it simple obesity?
No. Obviously, this is not a case of simple obesity, and my audience is absolutely right. There is some features of cortisol excess here. One of the things that we have to remember is that the height faltering is there, but the weight is going up. So that is a clear indication that the problem is probably endocrinal. Now, if it is of endocrinal short stature, what could be the possible differentials apart from Cushing's? It could be hypothyroidism, it could be pseudo-hypothyroidism. We also have to think of any exogenous administration of cortisol maybe as a part of a treatment, so it could be iatrogenic. It could be acquired growth hormone deficiency as well. We should also consider Turner syndrome as one of the differentials. But here the case goes towards Cushing's, as you rightly pointed out, because of several things. Number one, there is violaceous stria. If you have morbid obesity, you would have pale stria. Number two is that there are mood swings. part of cortisol excess where you can have steroid psychosis. Then you have another thing, that is the child is finding it difficult to climb stairs. It could be due to obesity, of course, but you have to remember that it could be due to proximal myopathy, which is a side effect of cortisol excess. So the first diagnosis would be Cushing's, as you rightly pointed out, and we would have to test this child for why this. Yes, and we would have to test for why this excess of cortisol is happening. It could be a tumor, it could be iatrogenic, as I mentioned. So that needs to be worked up. And apart from that, we do have in the history no goiter, no galacturia, but we still have to rule those things out. So a prolactin level and a thyroid profile would also be merited to rule out other possible causes of endocrine problems.
So in this case, what I want to highlight is, if you see a short and fat child, it is just endocrine short stature. So just use, before seeing the child, before getting any history, if I just have the height and weight, I can tell you this is endocrine short stature, because short and fat child is endocrine, okay? So that's the learning point from this slide. And always in an obese child, don't have the preset of exogenous obesity, always ask for other history. So we got so many positive history here because we dug into the history, okay? So taking a detailed history and examining a detailed way is very, very important in order to find out the pathological causes of obesity. So in a busy clinic, you should not miss out these rare cases. And endogenous Cushing's is not as common as exogenous Cushing. So always ask a diet history and make sure they are not on any steroids. So for many things, steroids are being used, so all of you are aware of. So make sure from the skin ointment. So most commonly what I see in the OP is the dermatologist would have prescribed some topical ointment which contains steroid, and the mom would be very happily applying large quantities over large body surface area. So because of that, there is lot of absorption and it leads to exogenous Cushing syndrome. So make sure you see all the prescriptions in the recent past. Make sure if they are containing any steroids like clobetason and all. Like I had a child with exogenous Cushing who had diabetes, hypertension, everything. So you have to see the detailed drug history as well in such cases, okay? Okay, can you just tell me a basic approach for obesity?
Okay. So whenever you have an obese child, obviously you will be assessing the growth with the various anthropometric measures. You would also look at the pubertal stage of the child by doing a Tanner staging. And very important to ask about, when did this obesity start? So if you have an obesity starting at less than 5 years of age, that would be, as we have rightly pointed out, that goes towards a different direction altogether. Also, you would like to take a family history of metabolic disorders or dyslipidemia, etc. So once you have got that bit of history, then if you find that there is nothing abnormal, then you would have to think of exogenous cause. Then you would go into detail about the dietary history, what the child is having, what kind of lifestyle the child is having, what is the screen time, etc., etc. You would be looking at towards that. So the next comes the slow growth. So your weight is going up, but the height is either static or faltering. So then you would be going for the endocrine makeup. And as we pointed out, that an early onset of obesity, you have features of dysmorphism like a short foot metacarpal or something like that. You would have to actually do a proper clinical examination because you would miss this otherwise. And the other thing is the history of development delay or slow learning or others. There you would have to think of the syndromes. So this is how you would approach a case of obesity, and it entirely depends on a proper history taking and a proper clinical examination. As with all pediatric cases, that's how we approach initially. The investigations comes second, and you do it as per requirement only.
So what are the red flag signs of pathological obesity? Briefly, so that yeah, we can
Yes,
go ahead
of course.
faster. Yeah.
So, as we said, if there is delay in development, delay in growth, the pubertal stages are not reached properly. So, you are doing a Tanner scale. In the case that we just showed, the menarche had not been reached. Although the puberty was appropriate, the menarche had not been reached. So, you have to do a proper Tanner staging. Then the features of dysmorphism. Then food-seeking habit, hyperphagia. So the child, even the grandmother says he is always eating. So that is a warning sign, basically, I think. So again, the early onset, and if you have any visual symptoms, neurological features, those are indication that you could be dealing with a pathological case, probably something to do with the CNS. So delayed puberty, so suspicious features, delayed puberty, think of Bardet-Biedl, Prader-Willi, development delay, again Prader-Willi, hypothyroidism, pseudohypothyroidism, the short hands and feet, Prader-Willi. So a short fourth metacarpal, pseudohypothyroidism. So you have truncal obesity or a buffalo hump, violaceous stria, hypertension, think of Cushing's. And if you have retinitis pigmentosa or polydactyly, then as we said, the Bardet-Biedl and also Alstrom syndrome. These are very rare. You may not see, if you're a general pediatrician, you might not ever see any one of them. But Prader-Willi and hypothyroidism is not that uncommon. And Cushing syndrome, you have to be aware, as Dr. Soundaram rightly pointed out, iatrogenic causes are not uncommon at all.
Yeah. So question 4, Dr. Ganavi. 11-year-old child was brought with complaints of rapid weight gain, 20 kg in the last 2 years. So similar to the previous case. So there is rapid weight gain. And history of increased junk food intake is there, no physical activity, lethargic, feels breathless when he exercises for a short time, and increased screen time is present. So this is a very common scenario. And if you see, the height is on the 90th centile, the weight is above the 97th centile, BMI is clearly obese, and there is no goiter, the child is pre-pubertal, and there are pale striae. So does anybody want to guess this?
Shall we go with the approach? Now, Madam, Dr. Papiya, Madam, clearly simple approach she told. So first was age, puberty and the growth. So here in our case, growth, when we see that is what height we mean. Height is normal range, that is between the 75th and 97th centile. Whereas weight, you can see it is clearly above. And coming to age of onset is definitely not less than 5 years. He is around 11 years old. And third thing was puberty, which is his SMR is stage 2, which is again within the normal range. So what it is in the flow chart? Now at least you can tell.
So what do you think the diagnosis is here? Anybody wants to try quickly? We are running out of time.
The first cause, when there are no risk factors, no developmental. So first is exogenous. So we have already other risk factors in this child, like increased screen time, and he was
the sedentary
lifestyle, and he had junk food intake. So this is a common scenario, and it is an exogenous, right? Then.
So the main clue here is the height is well maintained. So you have to plot the MPH centile, and the height will be above the MPH centile for a overnourished child. So the overnutrition is going to push up your weight as well as the height. So only if the height is above the MPH centile, you will think of exogenous obesity, and you have to rule out all pathological causes before labeling this child. Okay. So what are the pointers to complications? So when will you worry about this obese child?
So we know it is always associated with various comorbidities, and these are the other. This our child, I think he had breathlessness, right? The other complications would be like he may present with headache, leg pain or limp due to slipped capital femoral epiphysis, or daytime somnolence, sleep apnea. Many children come with that. Abdominal pain, cutaneous acanthosis, and there are some conditions which may be overdiagnosed, which we should be careful, especially the small phallic size due to buried penis, precocious puberty in girls with lipomastia, and rickets in children with genovalgum.
So what are the comorbidities we should screen for?
So IAP standard treatment guidelines for obesity mainly have given the cutoff values for cardiometabolic screening. So first comes the cardiovascular. As we see, we have to screen for hypertension, hyperlipidemia, and coronary artery disease. Endocrine hyperglycemia, where we will be doing the fasting blood glucose levels. Then pulmonary, we have obstructive sleep apnea, gastrointestinal, neurological, based on the clinical scenario and the symptoms and the complications. But must know metabolic complications, there is a table given in the IAP where mainly they concentrate on the fasting blood glucose levels, triglyceride levels and the BP. These are mandatory which has to be screened.
So actually, like you can see that each and every part of the body can get affected because of obesity. So type 2 diabetes, we don't use insulin much, but though type 2 diabetes you think is simple, but they have more comorbidities compared to type 1 diabetes. So it is very, very essential that we prevent this type 2 diabetes so that they will have a better quality of life. Okay. So type 2 is more bad than type 1. That is a very important thing that I want all of you to know. So metabolic syndrome, Dr. Ganavi has already told you, the IDF criteria for metabolic syndrome is there must be central obesity. So the central obesity is diagnosed by a weight circumference more than the 90th centile. So that is a must criteria, waist circumference. Apart from the waist circumference, 2 out of the other 4 should be there. So high triglyceride levels, low HDL levels, hypertension and hyperglycemia. So waist circumference is a must and 2 out of 4 of the other criteria should be met. If these are there, then we label the child as metabolic syndrome. Okay, question 5, Dr. Venkateswari. What are the ISPAD recommendations for screening for diabetes in children and adolescents who are obese?
As a general pediatrician, I always used to wonder when a child comes and the child is obese, I always used to think what are the set of investigations that we need to do. So invariably, before reading this guideline, what I used to follow is if the child is really obese, the child has a bad acanthosis nigricans indicating insulin resistance and there is a family history of type 2 diabetes, I used to screen them. But then after reading these guidelines, I learned a few new things. The first thing is you actually screen asymptomatic children after the onset of puberty or at least only after they become adolescents. Okay, you don't have to screen them when they're very young. So that was the first learning point. Then what are all the risk factors that you should look for when you have to screen them for type 2 diabetes? The next slide. So if there is a strong family history of type 2 diabetes, okay, there are particular race and ethnicity, you find signs of insulin resistance like acanthosis nigricans. In the perinatal history, you find that this baby was an SGA baby or an LGA baby. The mother gives history of a very bad history of a gestational diabetes, or the mother has a strong history of type 2 diabetes, or the child is currently on some antipsychotic drug. All these things are actually indications, okay? And you find that this child has dyslipidemia, hypertension, this child has some other comorbidities, then there is no doubt you have to screen them for that. So we'll go back to the previous slide. So I would screen asymptomatic children after the onset of puberty or at least after they are 10 years of age when they have become adolescents and they have the underlying risk factors. So I would screen them. The screening test would be to do a HbA1c and your fasting and postprandial blood sugar. If I find that the screening is actually negative and the child is fine, then I don't have to keep repeating it annually. I just have to keep screening them every 3 years once. But if on follow-up I find that this child is actually, the BMI is rapidly increasing, I am worried that the risk profile is more and there is a very strong family history, then I would actually screen them annually. So the take-home message will be start screening asymptomatic children once they reach puberty or once they are after 10 years of age. Look for underlying risk factors and then screen them. If the screening is negative, don't keep repeating it. You can do it once in 3 years. If you're worried and there is an increased risk, then you can screen them annually. That will be the take-home points.
Yeah, so we'll go ahead with the next case. So question 6, Dr. Papiya. 17-year-old girl studying in class 12 has put on 12 to 15 kg weight in last 3 years. Previously was physically active, now sedentary. So it's just similar to the previous case. And portion size is normal, they say. Like every parent will tell you they are not eating too much. But if you see, they will eat lot of junk food which the parents will not disclose to us at all. They will tell the normal meal portion is, the meal portion is normal. So you should not be taken away by that. Okay, always look into the snacks they eat, that is the culprit. And portion size is normal, not much junk food. But this girl on the controversy says not much junk food. Periods are irregular and menorrhagia is present. So on examination, her height and weight, her height is good, 160 centimeter, and weight is 85 kg, and BMI is obese, 33.2. You can see the hirsutism on the picture here. So on the side of the cheeks, you can see that there is abnormal hair development. A girl is not supposed to have hair in these areas. So hirsutism is there and acne is there. So Dr. Papiya, can you tell us what are we dealing with here?
I think the audience has all guessed what this possible case could be.
Yeah.
Absolutely. So this is probably one of the commonest type of case which obesity which presents to us. They're referred sometimes by the gynecologists, by the family sometimes brings them because of the irregular period. They start getting worried about that. Sometimes the child herself wants to come because adolescent girl, she is starting to have body image issues and probably also subject to bullying. Because of the hairiness and etc. So this is one of the commonest things.
Yeah, so how will you manage this child? So we are not going to cover the hirsutism part. We are going to tell you how to manage obesity part of this question.
Okay, so basically the common sense approach to management of obesity in this type of case is to look at the energy balance. What is the intake and what is the output? So you have to take a very good proper dietary history, and as Dr. Soundaram rightly pointed out, you have to take the history from the morning to the night, what is happening, what is the child taking. I mean, I had a case where the mother was actually giving 2 tiffins because 2 years ago the school bus had broken down and the children had come home feel very hungry and very thirsty, and so then thereafter she kept on giving 2 tiffins, parathas and everything, and there was a boy and a girl. The boy used to throw away the other tiffin, and the girl, being the good girl that she was, she would have that entire tiffin. So you really have to find out what is happening. Junk food, as she rightly pointed out, there would be junk food consumed when the child is relaxing, sitting at home, watching TV. So the exercise would also be very little. Most of the extra time, apart from studies, would be spent on screen. So these are the things where you have to look at the energy balance. Now, when you plan the diet, something like this gives the parent a good idea about what is the right kind of food and also the portion size. So if you have a green, something that's fruits and vegetables, that's the protein intake, and that those red light is the one that you should avoid completely. You should avoid completely. So basically, the portion size are important, and there is a simple algorithm which is called 5, 2, 1 and 0, and basically 5 is you have 5 portions of fruits and vegetables, 2 is the number of hours at screen that you should use, and basically 1 is the 1 hour of physical exercise, and 0 is the amount of junk food. No junk food at all. Okay, and junk food includes the beverages as well, which are sweetened, and the other salty junk foods, which are, the children consume in large amounts, and those are also quite harmful. So basically, we will also look at the exercise regime, and basically, you should tell the parents that get the child to do simple things at home. So fetching and carrying, laying the dishes, going and getting something. Maybe you've run out of salt, so she can go to and get the thing from the shop. That's so everyday little activities every day, instead of providing her everything because she's studying. That's not to be done. And number 2 is try and ensure that she does some kind of stretching or aerobic exercise at least 2 to 3 times, if possible, about 5 times a week. That has to be planned because we live in a society where access to all these is not necessarily available. So you can ask for the child to go to swimming, but winter months swimming pools are closed. So what do you do then? So basically, you have to discuss this with the parents and ensure that they do some kind of stretching exercises, and the screen time is minimized. And again, you would have already heard about the good screen and the bad screen time. So the screen time which is mandatory, like the schoolwork and all that, that has to go on. But the other times, try to stop that. So we will use technology, we will use technology as well, because technology is something that we have to live with. Because as you know, India is now one of the digital countries of the world. We are doing so very well. So I would like to very briefly tell you about a few innovations that are happening in this, and we have to use them cautiously. While it could be a double-edged sword, if parental supervision is not there, then screen time could be misused, the child's sleep would be compromised, and those are not good. So let me just talk about a few things which are sort of technology-based things which can help. Exergaming is something which is basically exercise combined with video gaming. It is available for all ages. For the less than 5s, there is something which, you know, they are motivated to do some exercise and given points, and that helps to do the exercise, and it's in a form of game. For an adolescent, the same thing can be done. Again, the exercise is a part of a game, and there is an incentive or a coupon or something. The company which gives the coupon, they can redeem it from the from that and get something like maybe a school product or something. They can redeem that. So that is an incentive-based exergaming. It has been around for a while. There are several of them, and you can pick whichever you want. So internet-based, mobile-based apps are also there. Machine learning strategies are something that is again a wearable device which can be connected to your mobile, and the data that is collected can be used by the physician to predict how the child is growing, or what is happening with the diet and the activity, and also predict how to manage this child and what the long-term risk of this child could be. So this is one strategy. And the most recent one, which is very interesting, the social robots or the virtuous robots. This is AI based, and this could be something that is new on the horizon. Every day something new is coming up on this field. Basically the social robots are embedded with some zoometric or anthropometric measures, and what happens is that they have almost a person-like interaction with the child. So the child thinks of this as a toy, and the interaction, and the child kind of starts trusting this and follows the instructions as to the food that the child should have or the activity that the child should do. But of course, all this comes with the next slide. All this comes with the family commitment. The child cannot be left with all these devices by itself. There has to be family supervision, and the family commitment would have to be in terms of the diet. So the child is not given something, but the rest of the family has it. That won't do. So the entire family needs to have a good, proper diet. There should be at least a few family meals where the family sits and eats together, because that has proven to inculcate good eating behavior. So these are things. School can also have a role in this, because schools can teach the child about the good food and bad food. Simple things like what are the good foods, or the food pyramid. If a small child is shown the food pyramid as to what are the good food and what should be avoided, once the school says something, they tend to follow it because the teacher has said it, so that must be right. Sometimes what parents say is not so effective. And of course, social measures. the society in of itself should, have good, emphasize on good eating practices and exercise, of course.
Yeah, a quick sum up of obesity. So basically, though all gadgets are available, nothing is like going and playing outside. So first thing I would tell them is keep a timetable for exercise. So if you want to do in your free time is never going to come. So put a schedule like in school. So have a fixed time. Morning 6 to 6:30 I will walk. Evening 5 to 6 I will do badminton. So fix a timetable, let them follow. For diet, basically what you should tell is the main dishes. So your chapati, rice, puri, all the main dishes have to be cut down to just quarter of the plate. Your fruits and vegetables should be half of your plate, and fat should be very, very minimum. The little you take also, the more weight you will gain. So fat should be minimum, main dishes only quarter of a plate, fruits and vegetables 50% of the plate. Okay, so you have to concentrate on diet. I feel diet is the most important. Second is exercise. So these two are the cornerstones of basic management of obesity. So going on to the next question. So question 7, Dr. Ganavi. 17-year-old boy with morbid obesity on annual follow-up is noticed to have blood glucose in the diabetes range. So fasting blood sugar above 125 is abnormal. So the child's fasting blood sugar is 142 and postprandial blood sugar above 200 is diabetes. So this child has hyperglycemia 223, HbA1c is also above 6.5 and belanoprostatitis, which is because of the hyperglycemia, the child has developed fungal infection. So what do you do?
So here only lifestyle modification will definitely not help the child. Already it has gone to cardiometabolic complication. So we will start him on one of the drugs which the IAP tells the FDA approved drug only is the Orlistat. Only drug which is FDA approved for children, that is more than 12 years. But since we know metformin has been routinely used for PCOS and it has also been found effective in obesity. So this table shows the mechanism of action, average BMI reduction, age of use and side effects. I'm not going into detail. So just list out the drugs. Metformin we know it is a Vigonide and Orlistat mainly acts by inhibiting the lipase. The other group of drugs we have liraglutide and semaglutide which are centrally acting. So either the drugs act through the periphery where they increase the gastric emptying time or decrease the gluconeogenesis and increase the peripheral uptake, or they act centrally by increasing the satiety and depressing the appetite. So these are the drugs, that is the GLP-1, glucagon-like peptide 1 analog, which act in the center and also in the periphery by enhancing the insulin secretion and increasing the gastric emptying. And these are available as injectable forms. And these are also approved for more than 12 years, especially with diabetes. The other group of drugs include phentermine and topiramate. Topiramate we know it has been approved for epilepsy. Along with that, now in obesity also in combination with phentermine, it has been tried for more than 12 years.
Yeah. So we have seen the drugs here. So we have put the drugs in the cost wise. So metformin is the cheapest drug. Next cheapest is Orlistat. And the liraglutide and semaglutide are all very expensive. So and phentermine and topiramate we don't use in children. So the other three groups of drugs we use in children. This is the latest release, semaglutide here. So metformin causes minimal weight loss, however it can decrease your appetite as well. So the first line drug we use in exogenous obesity who has developed a comorbidity like this is metformin only. And we use insulin in such children with type 2 diabetes if the HbA1c is above 8.5% or the random blood sugar is about 250 milligram per deciliter. Okay, so that's what you should know. So when will you use insulin in type 2 diabetes? So in this case with mild hyperglycemia, just metformin will do. Sometimes these children can go into remission and they will have low normal sugars, but even then you have to constantly keep monitoring them because the diabetes is going to come back. So you have to maintain a lifestyle intervention and keep following up these children even though they go back into normal sugars. Okay, that is the learning point here. And question number 8, Dr. Venkateswari, child with morbid obesity has been on liraglutide for last 6 months. Poor compliance, not adhering to diet or physical activity, has obstructive sleep apnea, hypertension and prediabetes. So you have all the comorbidities here. And BMI is 37 kilogram per meter square. So what is the next step of management?
So here is a child with morbid obesity. The child has not responded to medical treatment. So though we have not started during bariatric surgery in our part of the country, as pediatricians, I think it is very imperative that we all need to be aware of it, at least of centers where it is being done and when to refer. So the indications for bariatric surgery in adolescents are when the BMI is more than 35 and the child has an underlying comorbidity, or when the BMI is more than 40, even without a comorbidity, this child is a candidate for a bariatric surgery. And there are only 2 types of bariatric surgery that are being advocated. one is a sleeve gastrectomy and otherwise a Roux-en-Y gastric bypass. This is a very interesting slide because in the sleeve gastrectomy, they actually remove the entire greater curvature of the stomach. They just put a clip across the whole thing so that they cut down on the size of the stomach, okay? So here it is a less complex procedure. It is one procedure which is more commonly done when compared to the Roux-en-Y gastric bypass, and it has a lesser risk of micronutrient deficiency, but there is an increased risk of reflux in this particular procedure. The next procedure is actually a Roux-en-Y gastric bypass, where they actually create a small pouch and then they connect it directly to they bypass the entire stomach, okay? So in this procedure, there is actually the weight loss is similar in both these procedures, but this particular procedure, there is a better glycemic control and the post-operative GERD is significantly less. But this procedure has more risk of micronutrient deficiencies. So both the procedures are advocated. Bariatric surgery studies have clearly demonstrated in those with not responding to medical treatment and who are morbidly obese, there is an average BMI loss of around 25 to 30% following the bariatric surgery, and it definitely results in an improved glycemic control and remission of your other comorbidities. There are multiple side effects, the usual short-term side effects which is seen in any surgery, especially in a child with obesity, they are at risk for venous thromboembolism during the immediate post-operative period. The long-term complications, as we discussed, can be an increased risk of GERD, the risk of micronutrient deficiencies, risk of cholelithiasis, as well as dumping syndrome. So though bariatric surgery is not being done, I just inquired Dr. Hemchand too, it's not being done in Chennai in children, in adolescents. It's being done in Apollo for the adults. So but as pediatricians now, we are all heading towards morbid obesity in our community. So we need to be aware of the indications for referring an adolescent with obesity for bariatric surgery.
Yeah, so it is very essential that we try diet, exercise, pharmacotherapy before sending a child for bariatric surgery. You have to prepare the child psychologically for at least 6 months before sending for bariatric surgery. Because once it is done, they are not going to have any appetite to eat whatever they like also. So I have seen kids who have undergone this procedure, they will say whatever food they like before also they don't feel like eating now. So they are going to have a lot of trouble post-op. So you have to prep them up very well before going ahead with this surgery. It's not simple as we think. Okay, so good preparation is required before trying this. Always, as much as possible, avoid surgery. Okay, thank you. So any queries you have? So I think we have covered almost all aspects of obesity. I hope it was clear to all of you. Any doubts? We are...
Thank you, ma'am. And the panelists, if obesity is fat galore, your panel discussion was facts galore. So there is actually a question from the floor for your panel, ma'am. Children on antidepressants like sulfitac for depression usually become grossly obese. Children on antidepressants like sulfitac for depression usually become grossly obese and have hyperprolactinemia. How to treat these children? Any drugs necessary for obesity and hyperprolactinemia?
So we see this quite commonly, the hyperprolactinemia occur with TCAs. So what we do is, and antipsychotics more important. So what we do is, if it is causing hypogonadism, the main problem with hyperprolactinemia is it will cause hypogonadism and amenorrhea. So if it is affecting the child, then we have to start on cabergoline. We can request the psychiatrist whether they can change to drugs which do not affect our dopaminergic pathway. But if they say that the child has major problems and this is the antipsychotic which is required, then we have to treat the hyperprolactinemia with cabergoline. Okay. Yeah, I am not able to. Dose. So dose, what we start is in children, we start with 0.25 or 0.5 mg twice a week or once a week depending on the levels of the prolactin, sir. So it is available as 0.25 mg and 0.5 mg tablets. So we start very slowly because they can have side effects like giddiness, vomiting, all that. So we give the tablet in the night. They can have postural hypotension and all. So what we do is after dinner, we ask them to take the tablet and then go to sleep so that they don't have the giddiness. So we have to gradually hike up the dose within a few weeks to months and see whether the prolactin is normalizing.
Okay, ma'am. Thank you. And Dr. Hemchandra, two questions for you. How common are local side effects for growth hormone therapy? Question. And the next one will be, how long can we wait after treatment of intracranial tumors to start growth hormone for short stature?
I think local side effects with the currently available innovator molecules are very minimal. The cold chain maintenance is good. As long as the technique and the necessary precautions are followed, they are hardly anything, even with the daily as well as the weekly growth hormone. Regarding intracranial tumor, I think a very close watch and a multidisciplinary follow-up is what is pivotal, involving the neurosurgeon, neurologist, and the pediatric endocrinologist and the ophthalmologist. Literature says waiting for 1 to 2 years after completion of definitive therapy is warranted before initiation of growth hormone therapy. Thank you.
Thank you. With that, we conclude the first session. Over to Dr. Manoj.
Thank you, Dr. Venkateswari ma'am, for chairing the session, and thank you all the speakers and panelists for this wonderful session.